I can't take progesterone, so now what? What is up with progesterone intolerance? We are going to talk about this today. I've had a patient recently with this, and I've had some emails about this. So I feel like this episode is really sparked by things that are happening in real life hormone practice. So let's just say you start your progesterone because you've heard it can help with sleep, calm your nervous system, regulate bleeding, or even balance some of the hormonal chaos of perimenopause, postpartum, or even correct a luteal phase defect. And for some women, it is amazing. They sleep better, they feel calmer, their periods improve, and they finally feel like their nervous system has settled down.
But then there's another group of women. They take the same progesterone and suddenly feel anxious, depressed, exhausted, bloated, irritable, dizzy, or just not like themselves. Some women simply say, I took progesterone and felt absolutely awful. So what is going on? How can a hormone that makes one woman sleep like a baby make another one feel depressed or anxious? Does it mean you're truly progesterone intolerant? And if you can't tolerate oral micronized progesterone, what are your other options? Today, we're discussing progesterone intolerance, why it happens, and every evidence-based alternative available.
Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. Welcome back to Hump Day Hormones. This is Season 2, Episode 82. Aren't you guys glad that we're not famous enough for you to have to listen to ads? I feel like that
Yes.
spot would have been a perfect place for an ad, and you would have had to skip through it. But lucky you don't have to do that.
We're not there yet.
Mm-hmm. If you want to have an ad on our show, let us know.
Feel free. Yeah.
We're not just advertising anything though. It's got to be.
It's gonna be hormone related, female related, energy related. We're here for it.
Yeah, humpdayhormones@gmail.com.
I love it.
So y'all know we love progesterone. I feel like we talk about it all the time. We've tried to rate our favorite hormones, and progesterone is always right up there at the top. And I feel like that's true across the board, probably with anybody who really knows their stuff about hormones. But anybody who's been following the Lindsay Clancy case, if you haven't, you need to get on board. So she is the mother that is accused of killing her children from a postpartum psychosis event. And we've had podcasts about postpartum depression before, and about how important progesterone is, and how high it is in pregnancy, and then how you just completely plummet when you deliver the placenta. So I've been screaming at the TV and the podcast and places that I've been listening about Lindsay Clancy, because they gave her 13 different psychiatric meds, Zoloft and I don't even know, Seroquel and Lamictal and Valium. And they gave her this cocktail of psychiatric meds, but not a hormone in sight. And so not that, that would have been the end all be all, but it would have been nice if somebody at least, I think they all recognized, okay, she has postpartum depression, postpartum anxiety. I don't think anybody realized that she was full on psychotic, but it would have been really nice if somebody had been like, oh, there's a hormone component here.
Yeah.
God love her attorney, Kevin Reddington. He briefly kind of pointed that out. Like kind of called out her psychiatrist on like, did you check any labs, things like that. And I was like, yes, but
check the labs.
I know. And in the psychiatrist's defense, I mean, it's not really part of, or it hasn't been part of their standard practice to like get into the medical side of things and check blood levels. So I'm not, faulting them for that. It's just part of our training. But you could always send them to someone like us. We get referrals like that all the time from psychiatrists. Like, hey, I'm not going to check these labs because I'm not going to know what to do with the results, but go see maybe some people who would. So anyways, progesterone's been on my mind, and we are going to, in a couple of episodes, have a psychiatrist on our podcast and kind of dive deep into postpartum depression and just Lindsay Clancy. So we wanted to kind of like, we were thinking about progesterone, and then like I said at the beginning, had these emails and recent patients and kind of, what if progesterone doesn't feel like we say that it's supposed to feel for you? So, what is progesterone intolerance? I feel like we'll just kind of get into that and like how you might know if that's something that you have.
Yeah. So it is real. I feel like we've seen things about it, whether that's on social media or whatever, that's like, that's not like an actual diagnosis. It is real. Obviously, we don't have like a ton of data or textbooks written even on like hormone replacement therapy. So not shocking that like we don't have a lot of info out there about progesterone intolerance, but it is something in practice that we see. And, you'll hear that estimates around 10 to 20% kind of have this progesterone intolerance, but the number isn't well established in high quality trials. So it's hard to know, is it like progesterone intolerance or is it progestin intolerance? So looking at like the synthetics versus the bioidenticals, they're not the same.
I know. And I feel like, shocker, there's not a bunch of studies like in women's health, but on this. And then I feel like when there are studies, sometimes they just lump them together, progesterone and progestins. And so you can't tease out like
which is which.
Yeah. So, that's all kind of frustrating stuff. But and you'll hear like Heather Hirsch, who's big in the hormone world, says it's a third of people. So I don't feel like it's that much. I feel like in practice, most people really like progesterone. But there are,
I feel like I would say it's less. She says it's a third love it, a third are like indifferent about it, can't really tell either way, and then a third absolutely hate it. I don't feel like it's that high, but based on what we see, but it's definitely there in a handful of people.
And like recently I did a hysterectomy on a girl. She has endometriosis. We sort of discovered that at the time of her hysterectomy, and so I talked with her about like progesterone would be beneficial for you because progesterone would kind of slow the growth of any kind of microscopic endometriosis that inevitably, is there and got left behind. We can't see like every single cell in your body when we're in there with our eyeballs, but, progesterone would be good for you. And she was like, oh yeah, totally, like on board with it. And then like 3 days in was like, but it got a little confusing because it's like, is she just feeling bad because she just had surgery and everybody feels bad? And then she accidentally forgot her progesterone for a couple days and she felt better. So I think, and that's the other thing about it. I feel like if you have progesterone intolerance, it's going to show up pretty quickly. It's not going to be like, oh, I've been on this progesterone for 2 years and now all of a sudden. I feel like it's going to show up pretty quickly when you take it. But some common complaints might include, so like the opposite sort of what we say, or like too much of the effect of what we say that progesterone would cause. So it usually causes our mind to sort of calm down. Some people have too much of that, and then they're like, too dull, like they're emotionally blunted or almost feel depressed, fatigue, brain fog, or it can have the complete like paradoxical reaction where it makes you anxious. So it's like those people that say they take Benadryl and then they can't sleep and they're like hyper, it's like does the opposite of what it's supposed to. Breast tenderness, I feel like that's just kind of a beginning of taking any hormone, probably. Bloating, water retention, headaches, or like my patient that had it said she felt hungover. She just basically just felt like dull and draggy and hungover all day. And she even said that it gave her low-grade fever. I don't know how much of that is truly progesterone, or again, like she had just had surgery. So, but yeah, the whole like, I just don't feel like myself. That's a classic hormone line that we hear all the time, and you have to kind of investigate your way through it.
That's right. And so let's dig into like, why does this happen? Right. So kind of what we know about like progesterone is it breaks down into allopregnanolone. And so thinking about it that way, that it's not actually the progesterone, maybe that's the problem. It's the allopregnanolone that is like how your body responds to it. And everybody's body responds a little bit differently to that. So normally this would help like calm your nervous system, help with like cortisol response, improve your sleep, reduce your anxiety, which all of those symptoms seem to be like so heightened during perimenopause, right? Like that's kind of, where we see women and it's like, oh, you need some progesterone. And it works by stimulating the GABA A receptor. So similar to an anti-anxiety medication, we call progesterone nature's Xanax, and then some people are like, that was not my response to that. Like that was kind of a complete opposite response, So yeah, let's kind of talk about like what the problem is, maybe with that, not what their problem is, but maybe what the difference is in that person's body that doesn't respond to it well.
Yeah, and I think if we keep in mind, like it's not the progesterone, it's the allopregnanolone. And so it's kind of the same thing with testosterone. If you take testosterone and start getting oily skin and acne and, back knee and, chin hair and all this, it's not really the testosterone, it's the dihydrotestosterone, which, the other obvious statement is you're on too much of it. I mean, that could apply with anything, but people are different converters. And so how quickly you convert your progesterone to your allopregnanolone or your testosterone to your dihydrotestosterone, this downstream metabolite, like how quickly you do that is going to be so different from person to person. And so you first of all never know, like, okay, I'm going to give this person a normal dose of progesterone, just like I gave somebody else, and she makes all the allopregnanolone, and then the other person might just make a little bit. So there's some of that going on. And then we apparently don't all respond the exact same at the level of that GABA receptor. So sometimes it's like what happens downstream once you bind the receptor is different. So instead of like some people making it feel calm, they may have the opposite of that, or it may be like too much calming and then they're depressed and emotionally flat. But I feel like this phenomenon and how this different, because progesterone is really high during our PMS cycle, like our luteal phase. And so this same phenomenon has been described with PMDD, postpartum depression, postpartum psychosis, and severe PMS. And so it's either this very abnormal response to normal progesterone, or it is, that you didn't have enough progesterone in the first place. So it's kind of like a very interesting phenomenon. It makes sense if you just alter levels, right? You just don't have enough or you have too much. That makes a lot of sense. But I think what's so interesting here is that if you look at people who all have the exact same amount of progesterone and allopregnanolone, then you start seeing that people still respond differently. And that has to do all with their GABA receptors. And so
And that is one tiny piece of like what goes through our minds whenever we're like evaluating and treating patients, and why this is really like such a complex kind of, position to have, because everybody does not tolerate hormones the same way. And you have to like listen to that person's symptoms and how they respond, even regardless. Like if all their labs look so beautiful, but then there's going to be this person that's like, I feel like absolute garbage and have like all these worsening symptoms, and then they may have the exact same labs as somebody else. And this girl over here is like, oh, I'm living my best life.
Yeah.
It's so different for everybody.
I do feel like in perimenopause, there is the whole like we stop ovulating effectively because our poor little eggs are old, and so we truly probably just aren't making any, right?
Yes.
And so I think if you tried to put them in categories like, okay, what's a PMS person? Maybe they have too much progesterone. It's like, well, maybe they have a normal amount and they just their GABA receptors respond differently. Where PMDD is like, you want to think like they just don't have enough. And so I feel like if you, on the surface level, you may be correct some of the time, but then we have to know that there's that underlying receptor issue too. And so I think, and when I was thinking about this and writing this episode, it's a very obvious question that I'm sure maybe somebody listening to this is thinking, like, if you're saying that I make progesterone in every ovulatory cycle that I have, that's the job, is to make the progesterone to support the implantation of this embryo, because our body thinks that we need to get pregnant every month, then how can I like be fine? And some people aren't fine. Some people have severe PMS and PMDD, but how can I be fine in my normal cycles? But then all of a sudden you give progesterone to somebody and they're intolerant of it. So how could that even be the case, that you can be allergic to something your body naturally makes, right?
Right.
I mean,
right.
So how would that work? And so I think in thinking about that, there's some theories there. There's kind of like five different little theories that we're gonna work through here. So
yeah. Okay. So the first one is just in your own luteal phase, your own progesterone rises gradually. Where if you were going to just like take oral progesterone, I mean, that has a very quick effect. It's not that gradual rise over, several days. So progesterone begins rising after you ovulate. It increases gradually over several days. And then over those several days, the brain has time to adapt to those changing hormone levels. So whenever you are giving or whenever you're taking oral micronized progesterone, your blood level spikes within 1 to 3 hours of taking it, and then it falls off a lot quicker as your body metabolizes that pill. So that, I feel like, is a pretty good explanation. Instead of kind of a slow gradual rise after ovulation, you're like taking some and then it peaks and falls really quickly. And that's just kind of the mechanism of how medication works. And so your brain just responds differently to those, larger peaks and falls.
Yeah. And I think always with hormones, we talk about that with estrogen too. It's not the like changing levels. Sometimes it's like how fast you change, right? It's like you fell off the cliff after you delivered the placenta and your progesterone totally plummeted.
Yeah.
Or these perimenopausal estrogen spikes with like, the bottom fell out and it, falls back to nothing.
Right.
So it's that rapid change that doesn't feel good. And I think some people have tried to like find a way around that in making like, you can get compounded like sustained release to try to make it like release slower.
Yeah.
But then the alternative sometimes is people say, well, then that made me too tired. Like, it lasted too long. Like we tell people to take progesterone at night so that calming and all that can set in and help you sleep. And then if you're sustained release, they're like, man, I couldn't get out of bed the next morning. So again, there's not a one size fits all. But the second little theory here about how do you not tolerate progesterone when you tolerate your own luteal phase is that it's not the progesterone, it's the allopregnanolone. So I know that's what we were just talking about, but that paradoxical response because they react with the GABA receptor differently. And so I love this example that I came across, and it was said that if you think of it like two people drink the exact same amount of coffee, so, and that'd be saying like we give people the exact same amount of progesterone. Okay, these two people, they drank the same cup of coffee or took the same progesterone. One feels pleasant and alert, and the coffee does what it's supposed to do and kind of wakes us up. The other person gets palpitations and feels panicky and sweaty. And so that the caffeine content in those cups of coffee was identical, but the person's nervous system and sort of reaction to that caffeine was different. And so I think if you think about it that way, that makes sense. And so the same concept can apply to allopregnanolone. So there have been studies that have shown that GABA receptors can change. And I think that's pretty crazy. Like they're not always like this lock and key, and they're, formulated exactly the same and do the exact same things downstream once they're bound. They are dynamic and can change. So they can change throughout our menstrual cycle in studies during pregnancy when our progesterone gets, 200 to 300 times the amount it normally gets. They can change after childbirth. Hello, Lindsay Clancy, during perimenopause and in response to stress. And so there have been animal studies where they've shown this, that how dynamic those receptors are. And we know from studies that actual progesterone or allopregnanolone levels are not different. Like you can have the exact same amount of progesterone and allopregnanolone metabolite, and still some people have different responses. So it's that rapid change that seems to be the problem. I think one study that's interesting to me, there was anybody who's a science nerd may care, a GnRH study, and GnRH blocks your hormone production at the level of the hypothalamus. So like way back there, primitive, you don't even get the process started. So they blocked basically any signal to the ovary to create ovulation, to create any kind of hormone production. So they just turned it all completely off. And then they added back progesterone, and only the women who had previously already been established to have PMDD had the response to the progesterone at the exact same levels. So that was a way to like cut it completely out. And then with adding it back, they could see that those responses still happened in the PMDD women. So that's
wild. It is.
I know. And then there's like the rat brain model. That's what's kind of weird about this too. You can't cut open our like human brain and look at it. And so we just have to go off of like what basic science makes sense, and then like little rat brain models, or maybe you could do something more identical to a human, but not a rat. But anyway, the key still fits the lock. Like the progesterone, the allopregnanolone still fits the GABA receptor, but different consequences happen after the receptor is bound. So, they've done those studies in animals. And so we know that this is true. It's not a theory. We know it's true in animals, but yeah, we can't biopsy a human brain and figure out if that's what's happening to us too.
Which makes it really hard because you really don't know how somebody's going to respond, and so it's all about just like educating them on like potential side effects and all the things, and just kind of keeping in contact with them and good follow-up. So okay, the third theory is that your luteal progesterone may never reach the same levels, and so this can be due to poor ovulation, which happens, especially as we get into perimenopause and we're just not having like good ovulatory cycles, shortened luteal phases, low luteal progesterone. So just changes there month to month, which also makes it a little bit difficult to nail down,
And those women will sometimes say, my periods used to be 30 days apart, 28 days apart. But now I'm having a period every 3 weeks. And that sometimes is a signal that like, oh, your period is, your cycles are shortened because you're shortening that luteal phase. I mean, it's not always that simple, but we're people that say 4 days of spotting before I start my period. Those people are plummeting their progesterone too quickly. And I bet that they wouldn't make the connection, but I bet if you ask those people, like, how is your sleep? How is your anxiety? There's been some changes with that too. So, and then the fourth little theory here is that the route of our delivery matters. And so obviously when our eggs and ovaries, and our corpus luteum make progesterone, it's not delivered by mouth and swallowed in through the liver. So oral progesterone may make much higher levels of allopregnanolone because of that, liver clearance kind of phenomenon. And so there's other ways that you can give progesterone that may not mount that exact same response. And just like we talked about last week we played hooky, but the week before that, when we were talking about delivering estrogen through a patch or a topical way to avoid the liver, same thing with the progesterone.
Yeah.
And so you may not get as much allopregnanolone if you go with vaginal progesterone or transdermal progesterone, or if all you're trying to do is protect the uterus and you just don't care about allopregnanolone at all, then you could use progestins or intrauterine progestins like an IUD, or they do make injectable progesterone. And they make injectable progestins too. That's what Depo is. But people use if you've ever had fertility issues or infertility or done IVF, you've done injectable, like actual natural progesterone.
Yeah.
And then lastly, I mean, this is obvious. Perimenopause changes the equation. Estrogen is fluctuating wildly. So we'll talk about in a minute that like they're kind of a pair, estrogen and progesterone. So when you start jacking around with estrogen, you start messing with your progesterone. And then in perimenopause, obviously you're not ovulating consistently or potentially at all for months on end, and your production all by itself becomes inconsistent. And then when your brain hasn't seen progesterone in a really long time, then we have a way to like, they've shown this with estrogen. When you take estrogen away from somebody, their actual estrogen receptors upregulate. So your cells start like putting out basically more antennas. Like, where is it? I'm trying to find it. And so the same thing can happen with progesterone. You haven't had it in a while. You've been inconsistently making it. And so your GABA receptors become way more sensitive. And then also, like, sometimes our neurotransmitters are changing. Obviously, sometimes we feel like we don't have enough serotonin. That's why everybody over 40 gets an SSRI. But, there's just lots of changes kind of going on in perimenopause and then your cortisol and all the things. I mean, there's just lots of ways that we've sort of changed the game on you. So.
Okay. So let's get down to like, is it really the progesterone? And before you're like, forget it, I'm done with this, let's kind of walk through like, what should we do next? So are you taking it correctly? Micronized progesterone should be taken at bedtime. And they recommend on an empty stomach because food can increase the absorption, which may then intensify the sedation and side effects. So
I didn't know that until I wrote
some people, that's okay. Take it with food. And some people, which I would almost think opposite, I would think if you took it on an empty stomach that it would be like more sedating, but I guess food kind of helps the absorption there.
I guess so. It's a fatty, like it's made from cholesterol. So like vitamin D.
Like, and you want to take that with food to make it
absorb.
I
just never thought about it. I just thought about taking it at bedtime. But if you're like me and you get like munching on all the snacks after your kids go to bed,
I know that would be hard. So I guess
mine's probably always taken with food.
Yeah.
No problem.
Yeah, I know. I guess it would be recommended to take like 1 to 2 hours after dinner.
Yeah.
Yeah, kind of let that food go, get settled in and digested.
Like, sedate, intensify that sedation. Let's go.
That's where I'm at with it too. Yeah, it's like, give me all those side effects. But if you don't tolerate it, you can lower the dose. So there are 2 like commercially available doses for oral micronized progesterone. We can also get lower dose compounded. Some women do better taking it cyclically. So taking it like on the last 2 weeks of your cycle. Some do better taking it all day, every day, every single night. So it's so different for everybody. So, and then we talked about you can get the compounded sustained release. So instead of having that big release and peak of progesterone within a couple of hours of taking it, this is going to be more of like a slower release situation. Yeah. And a lot of times they're more tired the next day because it is still releasing.
And I do feel like sustained release, maybe because it is such a slow, steady release, doesn't get you like really good levels, like to get to your uterine lining.
Mm-hmm.
They bleed, which bleeding's already a problem in perimenopause. So sometimes it's like not enough to control that either. But anyways, I mean, there's not one size that fits all.
Mm-hmm.
But I think this is so interesting too. There's evidence that if your estradiol is not enough, and so, I mean, good luck in perimenopause because it's going to be too much one day and then not enough the next day. But in general, like if you're rocking along with like average, not enough estradiol, then you can have more progesterone effect because estrogen is like sort of the opposite of progesterone. Progesterone's supposed to be like sedating and like calming and all that in our brain. Estrogen's the opposite. It's like energizing, revving up, getting those dopamine receptors fire, and it's all like that's why it's like a big deal in the ADHD world what your estrogen levels are. But so if you're like not enough energizing with the estrogen and then you come in with more dulling of the progesterone, well, that's not going to feel good. And that's going to make you feel tired and hungover. Like you needed a little bit of like the kind of excitement that estrogen causes. And so
you need both and a good balance.
Yeah, like somebody was talking about progesterone being like the dimmer switch and like can kind of like turn things down in the brain. But if you lights weren't all the way on in the first place because of estrogen and then you start dimming more, well, then it's dark,
Yep.
So, I don't know. I like a little analogy. It makes sense to me.
It does make sense.
Yeah.
Okay, so how much progesterone do you need to protect the uterus? If that is kind of where we're using progesterone, I mean, especially if you're menopausal, right? Like you still have a uterus, you have to have something to protect that if you're taking estrogen. So with oral micronized progesterone, 200 milligrams by mouth for 12 to 14 days a month is the regimen supported by the systematic review with evidence for protection for up to about 5 years is where the evidence lands. Is like if you take
just how long their study was, I think. So,
yes,
technically you can't say per the study, like, is that still good when you're 7 years out? I mean, probably they just didn't keep the study going, but yeah.
Those women took it 2 weeks a month for 5 years and they had adequate uterine protection.
That's right. Yeah. And so that same amount of days has been shown, like if you were using a progestin. But we really don't have evidence if you use it for less than 10 days a month. And so I think that's what I tell people, because I had a patient not that long ago and she was like, I don't know if I like progesterone. I mean, I just take it like every other day, or, she kind of had some like weird things she was doing with her progesterone, but it was working for her. And I was like, listen, I don't really care as long as you're not bleeding all the time and as long as you're taking it 10 days out of the month. Like, I mean, if it is working for you and you are happy with that, I want you to protect your uterus as long as you get at least 10 days a month. I feel like with science, I can tell you you're doing that. And so as long as it's 200 milligrams. So if it's 100 milligrams or lower or compounded or something just not straight up standard, then you may need to be doing that daily. And so again, like, talk to your provider, but there is evidence you don't have to do it every day if it's 200.
Right. So what, are the alternatives? Like, if we're like X on oral micronized progesterone, what else can you do? You can get an IUD. You can get a progesterone only IUD, which is so nice. I mean, if you need it for contraception, there you go. It's going to give great endometrial protection, and you don't get any of the like systemic progestin effects with it. It's just going to be contained right there in the uterus.
Yeah. And so I think, if your goal is to not get pregnant or to not bleed or to, just protect the lining of your uterus, and you don't like oral progesterone, then that's a great option. But it's not also giving you any blood levels. And so it's also okay for people who bleed a lot and maybe only tolerate 100 or like to not take their progesterone every day or whatever. It's okay to have both. Like, it's okay to have an IUD and take systemic progesterone. Because an IUD is not progesterone, first of all. It's a progestin, and it's not absorbed systemically. But even if it was, progestins don't break down to allopregnanolone and stimulate GABA. And so it's really working on a whole separate pathway, and an IUD is just not absorbed systemically. So,
yes, I do both.
You can do both. Yeah. And then progestins, I feel like progestins kind of get a bad rap because of the Women's Health Initiative. And there's a bunch of different progestins. Progestins are what's in every single birth control pill. Medroxyprogesterone acetate was what was in Prempro, and that's what gave progestins kind of a bad name altogether. But all progestins are not created equal, except that equally no progestin is micronized progesterone. That is what's equal about them all, is that they don't break down to allopregnanolone. They don't stimulate GABA. They're not, natural bioidentical. But there's a whole bunch of different ones. They themselves are not interchangeable. So they might have different reactions. And I think this is obvious if you remember, like, being on birth control or, people that talk about birth control. One kind of birth control pill gave them acne. And then there's other kinds of birth control pills we say are good for acne. And that really, the estrogen's all the same in a birth control pill. You just vary the amount of it a little bit. It's all like synthetic ethinyl estradiol, but the progestins in there are interchangeable. Like, you just need one to protect the lining of the uterus. Some of them have more androgenic activity and may cause acne. Some of them have less androgenic activity. And so, I think that basically is what makes all the progestins different. But then they also may be different in their risk to cause blood clots and breast cancer and things like that. And so medroxyprogesterone acetate seems to be like the biggest risk of breast cancer. And then things like drospirenone and levonorgestrel and norethindrone seem to be a little bit less. But it's not like we can say, okay, micronized progesterone doesn't cause a blood clot. These may increase your risk just a little bit, and this is the worst. I mean, you can't kind of really put them on a continuum like that, but I do in my brain. I do that in my brain.
Same.
Yeah.
I mean, and I'm just not using medroxyprogesterone. I mean, we have such better options now, and there's typically no need. So, I mean, it was the one that was made famous by the Women's Health Initiative. It was the one, when combined with conjugated equine estrogen, that showed a slight increased risk in breast cancer after about 5 years of use. It was never the estrogen group. It was never the Premarin group. It was that Prempro group, which we've said a million times, but I still feel like I have to reiterate it every single time, So
day.
No on medroxyprogesterone for me.
I know. And then, I mean, I do think if we're talking about just progestins in general, there's some evidence that they can decrease your insulin sensitivity. So maybe not be beneficial for insulin resistance, and that they can promote some sodium retention, and kind of create a little bit of bloating and potentially promote visceral fat. So I think from a metabolic standpoint, natural progesterone and progestins are very different. It's like my pet peeve when people interchange micronized progesterone with progestins. But I understand because they like almost sound the same, but just chemically what they're doing in your body are completely different. But I don't think we have to like say, I'm so scared of a progestin either. Like, I think ideally you could tolerate natural progesterone. If you cannot and you feel worse on it and you don't want an IUD, a progestin might be a good option for you.
Yeah.
You know? And so we have women a lot on like Slin, which is drospirenone. Or I'll have people on norethindrone. Because you know what progestins are like really, really good at is blocking the lining of the uterus.
Yes.
They will thin the lining of a uterus and they will make people not bleed. That's why they're what's in birth control. You can't put micronized progesterone in birth control, no matter how safe we think it is, because everybody would, if they used enough of it to block their endometrium, be walking around too tired. Or if we don't use enough that makes everybody tired, they would all be bleeding. And so, I mean, there's a reason why we have progestins.
And this is just, I mean, kind of a always conversation had in our space, because there's always somebody or 10 people that are having some like postmenopausal bleeding going on whenever we first start hormone therapy. And I mean, there are ways to, you know, obviously you start progesterone, you know, and if that doesn't control it, then we kind of move forward from there. But I mean, there are great, even like little combos like Activella, you know, that has bioidentical estradiol in it with norethindrone. And I think there's really good options out there if you cannot tolerate oral micronized progesterone and or you're having bleeding that progesterone is not taken care of.
Never fear. We will find a way. We will find a way.
I know. I'm not going to tell people that so much. I'm like, just keep being patient. Like, there is an option out there for you to take estrogen.
I know.
And to keep that uterus happy.
And then there is a medicine that I feel like we don't like talk about a lot. And I feel like, you know, there's a lot of people who've really never even heard of it. But Duovy is the name of the medicine, and it is a pretty exciting option, but it does have some limitations to it too. So Duovy combines Premarin, which that's strike one right there. It's a conjugated estrogen, just like Premarin. It is essentially Premarin with another medication called bazadoxifene. Bazadoxifene is a selective estrogen receptor modulator. This is where people's eyes start crossing. You really lose them. But a selective estrogen receptor modulator means that only binds some of my estrogen receptors, not all of them. So it's going to block estrogen receptors in the uterus, but not the bone, but not, not the breast, not anywhere else, not your bladder, not your brain. I mean, just in the uterus, because that's the only place we care about unopposed estrogen. Everywhere else, we're like fine with all the estrogen in the world. And so it is a way to take estrogen, albeit in the form of Premarin, but it's a way to take estrogen and then not have to take any kind of progestin or progesterone or anything. You just have this blocker. And so that's nice, except that it's Premarin and that it's like one dose. So the dose that's in Duovy is the dose of estrogen that you get. And it really hasn't been studied of like, well, I'll just take Duovy and then I'll put on an estrogen patch too. We don't have the studies that say that bazadoxifene is enough to protect the lining of the uterus if you're doing that. And so that sounds like a good idea. It also sounds like a good idea. Like, why can't we just get bazadoxifene and take my estradiol and then take my bazadoxifene? That's an awesome idea, except that they don't make bazadoxifene all by itself.
Right. Right.
They're big pharma, and why would they?
Yeah. And there's probably some insurance issues trying to get Duovy.
Yeah.
I feel like I've
always.
tried with one person before and it was too expensive. So, yeah, I
Oh.
think the one dose situation matters because what if you don't absorb that as well and don't get high enough blood levels for
No.
bone protection and all the things?
It's bothering
So-
me. I'm looking it up right now because it's bothering me that I can't. Is it 0.3 or 0.4? It's something like low.
It's a very low dose
yeah,
for
because it's
Marin.
usually like not even enough. It's 0.45.
I mean, it's probably going to take care of a hot flash, which, okay, that's wonderful. But yeah, is it going to be enough for a lot of women to give them all the like protective beneficial effects? I don't know. I mean,
yeah, I mean 0.45. We don't use Premarin a lot, and so people don't know. But if we were using Premarin a lot, I mean 0.45 would be one of the lowest doses. There's 0.3. There's one underneath it, but most people used to be on 0.625 or higher. I think of like 0.45 as like not even really kind of like half a milligram of estradiol. So it's just a very low dose. And yeah, is that really going to be enough for all the other things that we're saying estrogen's good for? Anyway,
that's right.
I mean, way to go, basidoxifene, but way to like kind of withhold it a little bit, big pharma.
Yeah.
Anyway, I probably should be nice about that.
Well, it's like there's so many other options. Like put it with oral estradiol, put it in a patch form with estradiol. There's let's get more towards bioidentical estradiol if we can.
Let's just make up a conspiracy theory right here. And that Premarin probably sponsored the drug. That I made that up. But it's probably true. That's what a good conspiracy theory does.
That's right.
And let's like spread this on the internet.
I mean, there's not money to be had in bioidentical estradiol.
Yeah. That there is if you're the brand name Premarin.
That's right.
Anyway, okay, topical progesterone cream. That's a good idea. Like we use topical estrogen creams. So why not topical progesterone cream? And so the problem here is that progesterone apparently is like a huge, like if you were an organic chemistry nerd, progesterone is a huge molecule. And it's a lot of things are hard to get across our skin, but progesterone is particularly hard and really, really inconsistent with who's going to absorb and who's not. So there is direct endometrial biopsy evidence showing that progesterone applied to the skin can fail to adequately oppose estrogen. So if you are a hormone provider, never, ever, ever, ever use topical progesterone as your endometrial protection. Like you would lose every time if you got in trouble or if someone got an overgrowth on the lining of their uterus, because we have direct science to say that that's not a thing. So this was a 2005 study. They were using 40 milligrams, which is a pretty good dose of topical progesterone for 48 weeks. So pretty long study, pretty good dose, but they didn't get a good enough protection on the lining of the uterus. So just don't do that. I'm not saying that you can't take a progestin or have an IUD and then use topical progesterone, or that you can't have had a hysterectomy and still need progesterone and use topical progesterone. I think, there's a lot of scenarios where topical progesterone may be helpful, or we use topical progesterone sometimes if people still make their own, like they're 30 or they're 25 or whatever, and they still ovulate, they still make their own progesterone. My progesterone is not the protection to the lining of their uterus. Their own ovaries are still doing that for them, but they just need to supplement it a little bit, maybe because of PMDD or PMS or whatever, and they like that topical route. That's okay. But I mean, I think it can't be the protection.
Yeah, and there's not a commercially available form. I mean, it's a compounded cream that you have to get. But yeah, it is usually going to be used more for like mood, anxiety, sleep support.
Yeah.
Maybe, which also, if you think about it, it's like, okay, well, it's not being used in the oral form. So how much allopregnanolone is it breaking down to? How much support is it going to give? It's hard to know. Some people like it. We don't use a ton of it. But if you've got a good endometrial protection already established and then want to maybe look into this, okay.
Yeah, go for it.
Something to think about.
I think the other really obvious question here is like, wow, y'all just made an entire podcast about how some people really don't like this. So can I just not take that? Like, can I just tell with progesterone? I'm telling you, though, the people who like it, which I think
far outweighs the people that don't.
outweighs the people that don't. And the people who like it love it. And so...
I mean, I have heard so many people, they're like, I don't care. You can take my estrogen away. You can take my testosterone away. Don't take away that progesterone.
Yeah. And I think, that's an obvious question. Can I just skip progesterone altogether? And like, if you've had a hysterectomy, like a hysterectomy, not an ablation, like you truly have not an endometrial gland to be found.
That's right.
Yeah.
It is not in your body.
Yeah. And you could have an endometrial gland to be found if you have endometriosis, like, right? Because that's endometrial glands outside of the uterus. And so I do think that, those are scenarios where I've had a hysterectomy, but it's still recommended that I take progesterone. So, but I've never heard of endometriosis, don't know what it is, got my hysterectomy for fibroids, and I hate oral progesterone. Okay, well then... rock on with your estrogen. And
yeah. And on the flip side, if you've had a hysterectomy and still love oral micronized progesterone, you can still take it.
Yeah. But it's all confusing, like who needs it, who doesn't, or what is happening. That's why always it's important to not just listen to us, but to talk to, your healthcare provider specifically about you and your situation, not just like what you hear.
That's right.
So I think in closing, like instead of saying like she can't tolerate progesterone or I can't tolerate progesterone, a more accurate statement would be the brain appears unusually sensitive to the neurosteroid effects of the progesterone metabolite, allopregnanolone, that causes the GABA receptor to adapt in different ways from what we see in most women.
I love that.
That's a very simple alternative explanation.
And so I feel like that explains too, like, okay, there are other options. There are other forms. There are progestins. There are IUDs. Maybe that one dose of oral micronized progesterone was not right for you. So
don't say you're allergic. Don't, that it's not really like that. Just say, I don't respond well to that.
Yes, that's right.
Yeah.
That's right.
Yeah.
And so always our goal is not to just prescribe everybody hormones, right? It is to find the safest, most effective regimen that works really well for you and that you agree with and that you can live with and that you're happy with and all the things. And sometimes that is not the first regimen that we start with. Sometimes it's the 10th, but we're here for it.
I know. I just want people to think about it. I just want people to know about it and be able to think about it and have an intelligent conversation about it, or be able to like really understand maybe why somebody like Lindsay Clancy just completely went all the way off the rails.
Sure.
After her babies were born, like what the heck happened to her brain? And aside from like opening up her skull and looking at it, I mean, that's why psychiatry is so hard. Yep. So I just want us to be able to like think about it and have a conversation about it. And so we are going to, I've been in contact with someone that works in the psychiatry department at UAMS. Like they have an OB psychiatry department over there. And she's going to come on the podcast and we're going to talk about.
I'm so excited about that.
I mean, she's not a hormone provider and like I'm sure will fully say that is not her space, but she is a psychiatrist. And so, having somebody's opinion that deals on the other side of things, is going to be so interesting to me. So that's the thing. I just want to dive into like postpartum depression and postpartum psychosis, because if we're honest, that's like all I'm like thinking about right now, because I'm watching every single minute of the Lindsay Clancy trial live stream.
And thinking about her little GABA receptors are just so sensitive.
Yeah.
And had no progesterone attached to it. No allopregnanolone.
Bless it. So, if y'all don't know who she is, I don't know why. It's just so relevant.
We're like obsessed with it up here, and oh my God, there's just more coming out about it every single day, and we probably do not need to specifically share our exact thoughts and opinions on it because it is very controversial.
Yeah.
But there is so much to be had and talked about.
I mean, I think it's a very obvious generalized statement that she had a psychiatric disorder and needs some help. And I personally think that hormones could have been part of that. And I am fascinated by how this labor and delivery nurse who worked at Mass General, like one of the biggest, most respected hospitals in our country, and was married with 3 kids. Like, how does that happen? I mean, and we probably, won't ever fully understand that, but I have to think that hormones were part of it. And so, and I just will think that. So.
That's right.
Yeah.
Okay. Reminder, everything we talk about here is for informational and supportive purposes only and is not medical advice. Your body is unique, and be sure to talk with your healthcare provider before making any changes to your health routine.
Yay.
We will see y'all next week.
We're going to take some new pictures today. So if anybody's been wondering why my face looks so bad, all these pictures we post every week, there was some Botox problems going on. I'm going to go today and I'm going to smile my biggest unbotoxed, brightest smile.
Yes.